trauma patient assessment, a lot of it on those normal findings is the same. So the physical exam is all the same when you look at the trauma patient. Everything about it, you focus more on the injuries, right? And it's more of the rapid physical exam. So the thing that you can remember about trauma the most is just rapid. Your exam and all your information gathering has to be very quick. You have a trauma patient, right? So literally, you could have. We learned this in shock, but you could have a trauma patient that's bleeding 1 minute, the next minute they're decompensating and they're dying. And I mean minute as in 60 seconds, not as a figurative phrase. So 60 seconds later, that patient could be dying. So the rapid assessment, it does take practice, but we'll work on it, and it's not an expectation for you to be able to do a rapid trauma assessment right now, but by the end of the class you should be able to. So MOI, mechanism of injury, you have some patients that are considered traumatic patients, but they don't really have a high mechanism of injury. You still go through the same process. Why did you call? What happened? Why did you activate EMS? What type of injury? If you can't see it, obviously if they have an arrow sticking through their head, you don't have to ask too much why they called 911, right? They have an arrow in their head, so that's a pretty good reason to call 911. But with no significant mechanism of injury, or what's sometimes labeled as a minor trauma, like a fall, someone from a standing position that fell, or a minor wreck or something like that, then you have to investigate it probably more like a medical, as you gather the information. You start looking at, was it a gun involved? Is it a stabbing? Is it a car versus car versus tree? The strength, the speed. Was there any airbag deployment? Anything that, like on a motorcycle, were they wearing a helmet? Were they wearing the leather jacket? That doesn't really do a lot, but motorcycle riders seem to think that. But and then, like an MVC, is there a big skid pattern? So you start sort of gathering all this information that we'll look at when we get into trauma, and trying to determine some things about the injury. When you look at pain, do they have pain over a vital organ? Right upper quadrant, the liver, do they have pain over there? They have pain in their shoulder, which is a sign of a spleen, ruptured spleen, and their pain in their left shoulder. So you start sort of, just like the medical assessment, you start gathering information up on the present illness. The physical exam is the same physical exam, just much quicker. And you're looking here that the mechanism, what is that pointing to the injuries? All right, so if Frank fell off the school, and you're looking at this open femur fracture and these lacerations, you're judging the height of the fall and the mechanism of injury, and you're saying, okay, well, that adds up. That open femur fracture adds up to the mechanism. So you want to make sure that in trauma you always expose and you look, you inspect everything. On your trauma assessment, you have 3 injuries on Frank that you have to identify and verbalize how you would go about treating that. If you miss an injury, then you could fail the skill. You probably will fail the skill. So inspect, always look, palpate, auscultate the lung sounds. Make sure they have present lung sounds. You're looking for anything abnormal. So as you approach here, Frank, all of a sudden you see the big laceration on his foot, right? That would be abnormal. And you if you're doing a skills exam here, the biggest thing you would ask here is this bleeding. Is there any major bleeding right here? Because obviously he doesn't bleed, correct? So that would be something that you would look at. Here, he's got blood on his pants, so you would notice that. Is there any different shape, any strange movement? Does he have movement? Is he moving his arms and legs, right? So a quick inspection as you're approaching the patient and as you get over them. Do your CABCs, have someone hold C-spine, do the ABCs. And as you're doing the ABCs, you're scanning the body for any other life-threatening injuries. In your patient assessment, it'll be, you'll see this. And so I'm doing my ABCs and I'll say, is that active bleeding from his leg? And so the examiner would say, no active bleeding or active bleeding. We could pour a bunch of fake blood all over the floor, but he wants to clean that up, right? So we do a little verbalization there as far as the bleeding is concerned. Feel around, touch the skin, make sure they have good sensation. In all the trauma patients, you want CMS, circulation, motor, and sensation. So we'll learn about that as we talk about splints. And then listen for absent or decreased breath sounds. Absent or decreased breath sounds in a trauma patient is a sign of a tension pneumothorax. And those are life-threatening. That would be something that you would have to identify during your assessment. You can't do anything about the tension pneumothorax, but you would need to identify it. If all of a sudden you come up here and you're doing your assessment and you listen to auscultate the lung sounds right quick and said there's no lung sounds on the right side. So you suspect the tension pneumothorax, what would you do next? Besides oxygen and all that, your treatment, what would be the next thing you want to consider? You auscultate breath sounds and they have absent breath sounds on the right. I mean, you got them on oxygen already. You're doing all your treatment, but you notice that you have absent breath sounds on the right. What would you want to consider? Yeah, they do. They have a tension pneumothorax. So you do suspect a tension pneumothorax. Now what do you want to do?
Figure out what caused it.
Let's say the fall caused it. See, now what do you want to do? You already have oxygen. Huh?
I feel like around it. Just to get to this one.
Yeah, there's no crepitus around it, just absent lung sounds. Is a tension pneumothorax life-threatening? Yes. So what do you want to do?
Rapid transport.
What else can you do? Yeah, all those are true in a sense, but you're here, you're still on scene, and you go, oh my, I have a tension pneumothorax. Huh?
Report it.
To who? Think about it. You're missing that one element we're trying to get you guys to get plugged into.
Is it the ALS?
Right. ALS. You'd want to consider ALS because you have a life-threatening injury here, right, that you can't fix. So you can only treat it to a certain small degree, so you can't fix it, so you want to consider ALS. The same way with the heart attack and a lot of other things. So we'll work that, consider ALS in, because when you start in the testing process in the medical emergencies, that's one thing that is there. It's part of the answers. Consider ALS. So you want to make sure that you're looking at that and say, okay, that would be the most appropriate thing to do. This acronym here, DCAT BTLS, you just need to remember that in the trauma patient, this is what you're looking for. You're looking for deformities, contusions, abrasions, punctures or some type of penetration, wounds, burns, tenderness, lacerations, and swelling. So when you're doing your trauma assessment skill, when you come in, or on the board or on your piece of paper, your blank piece of paper, go ahead and write DCAP BTLS down. So you'll remember that. Sample, DCAP BTLS, and so you'll remember that acronym on the things that you're looking for as you're sort of going through the assessment. This will make a lot more sense once we start practicing trauma assessments. So deformity, you look up there and obviously that guy has deformity in the proximal forearm, right? Which is a weird place to put it, but that could be some sort of fracture. Remember, I have better pictures for trauma, so you look at the deformity. You know, does he have any puncture? Is that a stab or a gunshot wound or some other type of puncture or penetration? Swelling? Yeah. That guy talked back to his wife. Wife hit him with something, golf club, forearm. Yeah. I seen some guy his wife beat him almost to death with a frying pan. He wanted eggs. I mean, we're talking an old couple, probably 70-ish. He wanted eggs for breakfast. She didn't want to cook him eggs. The male decided that, well, I want breakfast and you're not cooking it, so I'm going to sort of slap you around a little bit. And then the female essentially said, well, you want eggs, cook it yourself, and started beating them with a steel skillet. Both of them came into the hospital. The male was unconscious. He was beaten bad. So not that funny. Don't tell me you want eggs and start slapping me around. Anyway, vital signs, medical history. So if there's no significant mechanism of injury, even in trauma, you can take a little bit more time to be a little bit more thorough. But if there's a significant mechanism of injury, everything is sped up somewhat. So make sure that you get good baselines. You know, your senses will tell you a lot once you start doing patient assessment. What you see, what you hear. Do you hear gurgling sound? Do you see blood? Do you smell anything that's abnormal? That tells you quite a bit, especially if they're having like a GI bleed. Once you smell that, you never forget that smell. So your senses will tell you a lot. Are they telling you? Do they feel dizzy? They nauseated? They have chest pain? They have a headache? They have visual problems? So as we sort of work into more of the trauma, we pick up the signs and symptoms of these trauma patients, and it makes the assessment a little easier. It's a little bit more difficult now because you don't know all the signs and symptoms of these. But once you tie the signs and symptoms in there, the questions will come easier, and this will make a lot more sense to you. You use the same sample for the past medical history as on the medical patient, and then the same OPQRST. Trauma, one thing that you want to do in the trauma assessment is making sure your partner's holding C-spine, then go ahead and apply a cervical collar. The cervical collar limits movement in the neck, and we'll look at these during trauma. Limits movement, but it doesn't stop movement. You can still move your head in the cervical collar. It just sort of restricts the movement. You'd want to measure it using the finger method on the cervical collar. We'll show you that during the lab sometime. But Make sure it's the right size. Most everybody's a no neck. You people with hair, long hair, that's a problem. You know, the cervical collar, you got to sort of move the hair out of the way. But earrings is a problem. You don't want to get the cervical collar up where it's pushing in on the earrings and the necklaces and stuff. So just sort of, you might have to take those off. Let me tell you, EMS-wise, is they get necklaces. If we just don't spend a lot of time with the class, we just more time with the scissors. Take our trauma shears out and cut the necklace off. Put it in your pocket or something, okay? So, but just not a lot. You don't want to spend that amount of time trying to get that cerebellum to kick in and take those little clasp off, right? So we won't cut your ears off if you have earrings in, but those are a little bit more difficult to take out. It's a problem in trauma because you lose a lot of stuff. Try not to, if you take earrings out, the necklaces out, put them somewhere where you can remember where they are, okay? That is very important to remember about the patient's possessions, okay? You want to make sure, it may be that necklace may seem insignificant to you, but some things are just like really dynamic to the patient. So we'll learn how to apply the C-collar. You can sort of see there on the front. We worked on this last year, didn't we? Do the C-collars last year? Did y'all do any of that? Okay, we'll work on that during trauma. It's no problem. Figure, like I said, it doesn't immobilize the neck, but it helps sort of restrict the movement. With that, stabilize the head. And when you do your trauma assessment, always put oxygen by non-rebreather at 10 liters per minute on the patient. Always put oxygen on the patient at 10 liters per minute with non-rebreather, and stabilize the head and hold C-spine. Then request ALS. Just go ahead as you're working through that trauma assessment. Remember these things you're going to always do. Always request ALS. Always control C-spine. Always put the patient on oxygen. All trauma patients get oxygen by non-rebreather. All right? So that's one of those always. We're talking some more alwayses later, like keeping the patient warm. Always keep the trauma patient warm. Even in North Texas in August, cover the patient up, keep them warm. They're cold, they're losing blood potentially, so they're going to be colder than what you are. So always try to keep the patient very warm. Then do a rapid assessment head to toe en route. So now you're getting this information on your trauma patient assessment, and one thing that you want to verbalize, since we're not going to get in an ambulance and go somewhere, is I'm going to do all my assessment en route. You'll want to tell the examiner, as soon as I get the patient on the backboard, I'm going to do everything en route. And that lets them know that this is one of the things that you're thinking about. And then go through the head to toe like we just did. Using the DCAT BTLS, communicate well with the patient if you can, if they're conscious. Get the pain scale, do the OPQRST, do reassessment. When you reassess the patient, on a trauma patient, you would reassess critical patient every 5 minutes, a non-critical patient every 15 minutes. You want to do a complete reassessment. Head to toe, we already talked about that. Auscultate lung sounds, look for crepitus. Paradoxal motion, what's paradoxal mean?
Like paradox in English?
Well, this says paradoxal motion. So, but it's probably the same word. What does paradoxal mean?
Oh, it's when like, I feel like a floating ribs and they're turning
Yeah, right. It's like a flailed chest. You get opposite. Paradoxical motion is opposite of the other side. So if you're talking about the ribs, one chest wall goes out and the other goes in. I think we watched that video last year on the flail segment. If not, we'll watch it this year. It's pretty cool. Assess the chest. Look at the chest. Inspect it. Palpate the abdomen. All four quadrants. Pelvis, extremities. Look for, the decap BTLS. Get good sensation. Then have y'all read priapism? It's only in a male. It's a constant erection, but the thing with it is it's a positive sign of a spinal cord injury. I've only seen 2. We'll talk about it more during the spinal cord, that chapter, but it's sort of weird. I'll just tell you that now if you ever see one. But it's telling you that the patient has a high potential of a spinal cord injury. Make sure you always check CMS, circulation, motor, and sensation in all 4 extremities, like they're showing here. Before you place them on the backboard, you do a log roll and you examine the back. You're palpating down the midline, down the spinal column to see if there's any deformity or crepitus or any tenderness there as well. And then the other exam, once you get en route, the detailed exam is just the same as the medical exam. You keep gathering information. You want to treat what you see, if you can treat it. If you can't treat it, then at least identify it, and then keep reevaluating. Be careful with exposing your patient. I understand that you have to expose your patient and see the injury, but once you're finished, cover your patient back up. Nobody likes, because you can imagine what this would feel like. You're strapped down to the board, all right? You're injured, you're in some kind of traumatic accident, you're having some EMS person cut your clothes off so they can see the injuries, and then they just leave you there, strapped down to the board with your clothes halfway cut off, right? So make sure that you once you expose and once you sort of look at the injuries, that you cover the patient back up. Just don't leave them out there. Huh? Well, they're not nude, but their clothes are, they look a lot like Tarzan, you know. I mean, you don't have many clothes on. They're all cut into strips. This is a sort of an algorithm that we worked on last year, and it allows you, and we'll go into this in more detail later. I don't really want to do this right now, but when we look at this is a good, I'll give you a copy of the better one. A student did this for me last year, and it was my fault. I didn't proof it well enough, and there's some typos in here. But I will give you a copy of the one that's sort of fixed. But this is a good algorithm, and all medical people work on algorithms. So you do a pre-patient contact where you do your BSI, scene safe, you size up, always thinking sort of worst to least. Do you need additional help? Is it safe for me to be there? You develop a plan of action. You avoid tunnel vision. You want to keep your sort of an open mind and gather as much information as you can. You make plans according to your abilities. Think big. You're thinking worst here, so you're thinking big. What could this be? Then you get into sort of a patient where you do patient contact. You're still sizing up. Is ALS needed? more than likely. Good general first impression. Want to organize all my assets that I have, because when we talk about trauma, we're talking about fire and rescue and other assets. Do the level of consciousness and the AVPU. Are they alert and oriented to person, place, time, and event? Sample, OPQRST. And trauma, you do your DCAT, BTLS, baseline. So see how it sort of flows down? And then somewhere in between here, when you start doing your sample and DCAT, BTLS, you merge over here and you start doing the treatment. You know, make sure that you remember your 4 life-saving steps. Anybody remember those? Start the breathing. Stop the,
Protect the wound.
that's right. Start the breathing, stop the bleeding, protect the wound, treat for shock. If you can remember those 4 things, you cover most everything. So to do that, always treat for shock. We'll learn a lot about that. I'll have this up where we can see it later, because this is the algorithm that we're going to work through as we do patient assessment. You get in here, do I need pharmacology? Do I need medical control? That's supposed to be medical director. But focus, exam based on chief complaint. You reassess and you treat. You look for the patient declining instead of getting better, they're getting worse. And then transport as soon as possible. Use those good systematic approach and that good critical thinking. But we'll see this over and over as we work in our groups and patient assessment. This is how you're going to systematically sort of work through the assessment process there. Questions? Oh, very good.